Bismillahirrahmanirrahim. Today I'll be talking about the basic tools of CTO intervention. And I would start my presentation with the most important tool you need to have in the cath lab, and that is an ACT machine. So you need to have your ACT checked every 30 minutes. And for a retrograde approach, you need to be keeping it above 300. And another important thing is that don't use 2B3A inhibitors in these cases because you'll end up in pericardial effusion. So the first things that you need are arterial sheaths, especially long sheaths for the femoral. And nowadays, you have slender sheaths for the radial artery, from which 6 French sheaths you can use 7 French guiding catheters. So you need guide catheters of all shapes and sizes. Any guide catheter that fits into the coronary is good enough. And for the right coronary artery, sometimes you might be needing guide catheters with side holes. Now, another important thing is that your guide catheters need to be short for the retrograde guide. And you can find 90 centimeter guide catheters from different companies, but sometimes they are not available here, so you need to shorten the guide catheter. And this is how you shorten it. So you take a 100 centimeter guide cath, cut out a 10 centimeter portion from it, take a 6 French sheath and cut a little portion from that, and dilate the ends of this sheath with a 7 French dilator, and then you can connect the two ends of the guiding catheter with this portion of the sheath in place. So this will give you a short guide catheter, which can be very important at times, and you can end up in a failure if you don't do this, especially if you are using epicardial collaterals for the retrograde PCI. The next equipment that you will be needing would be guide catheter extensions. They'll be very commonly used, especially in retrograde PCI. So there are mainly guide liner, guidezilla, which are commonly available here, and a trap liner, which is a guide catheter extension plus a trapping balloon, which we don't have here, but it is a very useful gadget to have in your cath lab, for especially if you are doing antegrade dissection and re-entry. So this is the example of a guide liner extending almost in the distal to the mid RCA. So this adds to the support. So you can see that even the guide cath is an implants one guide cath, and sometimes so much support is required that your guide liner is down into the mid RCA. So this is the trap liner in which there is a guide catheter extension, and you have a balloon which you can trap intermittently for introduction and removal of the microcatheters or balloons. And the important thing regarding this is that every time you have to introduce a trap balloon once you are changing equipment. So in this, a lot of time is saved, and it's very user-friendly. So if you don't have a trap liner, then you need to use trap balloons, and you need to be familiar that you will be needing at least a 2.5 millimeter balloon for a 7 French trapping, and if you have an 8 French guide, you need a 3 millimeter balloon, because otherwise there won't be adequate trapping. So microcatheters commonly used are the fine cross, the turnpike. Caravelle is a very good microcatheter for retrograde epicardial collaterals, and various types of Corsairs are very good. So if you want to have one microcatheter in your lab, this is probably the one you should have, because it has a multi-purpose use and you can rotate it. You can use it both antegradely and retrogradely. So this is a very useful tool. So there are some microcatheters like the Taunus. They can be sort of screwed into the plaque and help you progress when normal microcatheters are not passing. So we have dual lumen catheters, which can be useful in CTO PCI, like the Crusade, Twin Pass, and the Sasuke. So we have some angle tip catheters which can be very useful at times, like the supercross catheter, which is an angle tip catheter which comes at various angles, and a venture catheter, which is a steerable microcatheter. So another microcatheter is the recross microcatheter. It can be used for recrossing for antegrade dissection and re-entry. So you can say that the recross microcatheter is a cheaper sort of version for antegrade dissection and re-entry. So there are lots of microcatheters, but I think what you need to know is that you should have Corsair or Caravel, Supercross catheter. In the dual lumen, you can have any one of these, and either Tornus or a Turnpike Gold. So this, each one from this category would suffice to make a good toolbox. So guide wires, you use Varicose wires to reach the proximal cap. Then if you have microchannels, you can use tapered polymer jacketed wires like the Fielder XT. And for traversing the CTO body and sometimes knuckling, you can use the polymer jacketed wires, which are relatively heavier tip load, like the Pilot 200 and the Gladius. Ultimate Bro 3 is also a very useful wire in this regard. Now, the stiff wires like the Confianza Pro 12 and the Astato 20 can be used if the proximal cap is very hard and calcified. So we have the Gaia group of wires, the Gaia and the Gaia Next, have sort of revolutionized CTO PCI, especially increasing the chances of antegrade approach. So the Scion, Scion Black, and Suo 03 are the wires which you can use for retrograde PCI, especially the Suo 03, which can be used for very tortuous epicardial collaterals. Now, there are certain wires like the Miracle 12, Grand Slam, BHW, or the Mailman, which are very supportive wires. And once you start stenting, you will need a lot of support to sort of carry your stents down the vessel. So these wires can be very useful. Miracle 12 can also be used in antegrade dissection re-entry for stabilizing your system. So RG3 wire is the externalization wire after you've crossed through the retrograde approach. So if you don't have an RG3 available, you can use a rota wire because its length is more than 300 centimeter. So again, this is a diagram showing that if you have microchannels, you can use a Fielder XT, a hard calcified entry, you need a Conquest Pro 12. And for traversing, you need a Gladius. And the most important steerable wires nowadays are the Gaia and the Gaia Next, which are very useful. And this is the Suo 03 wire, which we don't have here, but this is supposed to be a very safe wire for traversing tortuous epicardial collaterals. Then we have antegrade dissection and re-entry. We have the cross-boss Stingray catheter, the Stingray wire, Miracle 12 to stabilize the Stingray catheter. For re-entry, we can use either the Stingray wire or wires like the Confianza Pro 12, Hornet, or the Astato 20. And trap liner, which I showed before, is very useful because once you sort of engage the trap liner, it will not let the subintimal space to increase. So the success of your antegrade dissection re-entry will increase. Now the recross microcatheter, which I've mentioned before as well, is the cheaper way of antegrade dissection and re-entry. And it is a catheter with 3 exit ports. So once your wire goes subintimal, you can use this microcatheter and use one of the re-entry ports to get back into the lumen. So this is the Stingray and the crossboss catheter. You first take the crossboss catheter and traverse the subintimal space, and then you use the Stingray catheter, inflate the balloon, and re-enter from its exit ports. And now this is the recross microcatheter. So it has 2 OTW ports and 1 port which is from the tip. And so through this 2 exit ports, which you can see there, these are 180 degrees apart. So once your your catheter is on the subintimal wire, you can use these ports through the over the wire systems to re-enter into the main vessel. So the other tools and equipments which you require are sometimes you need good quality balloons, atherectomy devices. If there's lots of calcification, you will need imaging for optimization of your stents, and covered stents, microcoils, snares. These would be required in cases of complications, and you must be having a complete inventory of all the coils and covered stent whenever you are doing your CTO PCI. And angioseal and proglides, these are the closure devices because you use 8 French femoral, so these could be very useful. So the small profile balloons, the basic theory is that they are used for wedging or ice breaking so that the passage of bigger balloons is made possible. So IVUS can also not only be used to optimize your results, but also for entry into the ambiguous proximal cap. So now your toolbox should be as simple as possible. You should be familiar with the kit and use the same things frequently. And you should be aware of your device options. And don't get carried away. And always remember that in a CTO PCI, failure is acceptable, complications are not. Thank you very much.
Thank you, Dr. Nadir, for a comprehensive talk. So we have a talk coming up for the next session, but we have preponed it to this session. It is going to be by Dr. Khusrow Naizi. He's going to talk on venous disease interventions. Should us, the cardiologists, be involved? Dr. Khusrow Naizi is a peripheral endovascular interventionist working with Emory University, Atlanta, USA. So, are we going live? Okay. So, Dr. Khusrow Naizi.
Can you hear me? Hello? Hello?
Hello.
Can you hear me?
Yes, Dr. Khusrow, we can hear you.
Okay, you will. Assalamu alaikum wa rahmatullahi wa barakatuhu. You will have to let your IT guy let me share my screen. He's not letting me share my screen. Host has disabled participant screen sharing.
We are working on it, Dr. Khusrow.
Okay.
Okay. Dr. Khusrow, can you try again, please?
Okay. I think now this is going to work probably. Can you see my screen?
Yes, we can see your screen and we can hear you clearly.
Excellent. Let me go into the... So this will be a 10-minute talk. This will be a very boring talk because after you have heard all the exciting talks of the complex coronary interventions. But the issue is that this is a far more common disease than coronary artery disease. So I'm sure a lot of the patients, they have this disease, but it gets undiagnosed. So without further ado, we have patients in our waiting room, and this is the big elephant that we missed. That's the peripheral vascular disease. And under PVD comes the peripheral arterial disease and venous disease. This is how the patient's legs may look like. This is an early sign where you see pigmentation of the skin. Or if this is the extreme end where they form these venous stasis ulcers above the ankle, which are chronic, they take a long time and are very frustrating for patients because it keeps on oozing fluid and causes a lot of agony among our patients. This is a combined arterial and venous ulcer. So it doesn't mean that anything above the ankle is always venous. This is arterial and venous combination. So let's talk about the incidence. We all know the heart valve disease, cardiac arrhythmia, stroke, congestive heart failure, peripheral arterial disease, coronary artery disease, and venous reflux disease. And if you look at these, this is where venous reflux disease is, a very common disease. But fortunately, a benign disease, but it causes a lot of patient suffering. And if we add to the venous disease, peripheral arterial disease, then peripheral vascular disease is far more common than the other cardiac disease that we see. I've made this very simple for people. When patients come to you with leg discomfort or ulcer, then most of your diagnosis will be based on history. 95% of the time, if you get a good history, you will have an idea what tests you would like to get. Physical exam can be helpful, but you want to put these patients, either it's arterial insufficiency, for which you will get an ABI. If it's venous insufficiency, you will get a venous Doppler, and then the other causes which are non-vascular. So what about the risk factors for chronic venous insufficiency? Most common is heredity. If their parents had venous insufficiency in the form of like varicose veins or leg swelling or pigmentation, then the chances of children getting it is very high. In fact, this is more transmittable genetically than diabetes. As we all get older, this disease becomes more common. Women tend to have more. Obesity exacerbates it, pregnancy exacerbates it, and prolonged standing. So it's commonly seen among nurses, physicians, flight attendants, and in tall people, it can also be seen more commonly. The spectrum of varicose veins, the most common symptom is leg pain or aching or heaviness, but they can also complain of severe cramps at nighttime, leg swelling, itching, restless legs, formation of varicose veins. Spider veins is not essential. You can have spider veins but not have this disease. And obviously, very large varicose veins, you can form stasis and blood clots. And if you break down the skin, it will tend to bleed a lot because the pressure in the veins goes up to like 100 millimeters of mercury. Normally, the pressure in the vein is 0 to 1 millimeters mercury. But when the pressure goes up, then these veins can bleed a lot. And obviously, the stasis ulcer that we mentioned earlier. If you look at the location of the ulcer, arterial ulcers will tend to be on the toes or the foot or the heel. Whereas if you look at the venous ulcers, they will be more above the ankle, the gaiter area which is called. But that's not always 100%. As you see, mixed arterial and venous ulcers can also happen above the ankle. But that gives a little idea. How many of you have your patients take off their shoes and socks? At least in America, most cardiologists, they listen to the heart, they may listen to the lungs, and that's it. And they don't even look at the legs. But remember, you guys are not cardiac specialists, you are cardiovascular specialists. So I think it's a good idea when you're doing a physical exam to look at their legs and to check their distal pulses. As I said, this is a combination of arterial and venous disease. We first treated his trifurcation disease, we improved the inflow. And this is the patient's history, and I won't waste time because his ABI after 8 weeks after improving the arterial circulation was normalized. And then 4 weeks after presentation, the wound had started healing after we had treated the arterial disease. And then he had severe reflux in the left great saphenous vein, and we treated that with ablation. And 4 weeks after the present ablation of the left great saphenous vein, the wound had completely healed. This is the patient. He had already had undergone amputation of the right leg. Unfortunately, he didn't see me before getting the amputation, came to me afterwards. So it's important that we stop this amputation epidemic. Now, what's the prevalence? We already talked about that. It's very common in the US. A lot of people miss work because of the leg symptoms. Most common leg ulcer in wound centers in the US is venous stasis ulcer, not the diabetic ulcer as is commonly thought. And 5% of the US population suffers from some type of leg vein abnormality. As you see over here, as we get older, the disease becomes common. Above the age of 60, 2/3 of women will have it, and about more than 40% of men will have this disease. Just to explain the anatomy, because when I became interested in venous disease, which was about 15 years back, I realized I had to understand the anatomy. So in the leg, the way I explain to my patients and young doctors here is, think the bone is in the center, that's surrounded by muscle, and then the skin. Between the skin and the muscle is the saphenous sheath, which is this yellow line over here. And the blood vessels that are deep in the muscles, those are the deep arteries and the deep veins. And the veins that are in the saphenous sheath and between the skin and the saphenous sheath are called superficial veins. So let's talk a little bit about the anatomy. So if you draw a leg diagram, these are my own drawings. And this is the deep venous system. So basically what you have is you have the common femoral vein, which then is called the femoral vein. We don't call it superficial femoral vein because it's really not superficial, it's a deep vein. And then the popliteal vein is behind the knee, and then you have the deep veins of the calf, and the gastrocnemius veins and the deep femoral vein. Now, if you draw another diagram for the superficial venous system, you have the great saphenous vein that travels from the medial malleolus, goes all the way inside, and comes and joins the femoral vein to form the common femoral vein. This is a superficial vein, and it gives many branches. There are anterior branches, there are posterior branches, but this is the main vein over here that goes all the way down. And then there's another superficial venous system which is behind, which is called the small saphenous vein, which runs on the lateral malleolus and comes behind the calf and joins the popliteal vein. And sometimes it can give a cranial extension, which is called the vein of Giacomini, which wraps around the medial thigh over here. So understanding the anatomy is important. The pathophysiology is basically a chronic inflammation that happens in the valves, which makes the valves dysfunctional, and the blood that goes up starts refluxing back. How do you diagnose it? Ultrasound test. And the test has to be done with the patient standing. You don't diagnose this disease with the patient recumbent. And once you evaluate for venous occlusion, thrombus, and the deep venous system, you map the course of the incompetent superficial veins. And this is on ultrasound how it will look like. This is the saphenous sheath, and in between the saphenous sheath is this great saphenous vein. And below the saphenous sheath is the muscular compartment here. And the transducer is sitting up over here at the skin. This is a real-time flow which shows you the great saphenous vein, and the skin is over here, the muscular compartment is back, and you can see a branch coming off the great saphenous vein. And this is how the color flow will look like. Towards the head is this blood flow, and this is refluxing back. So you can measure the time duration of this venous reflux and estimate the severity. This is how the color will look like. Blue goes towards the head, red comes back. This is at the saphenofemoral junction. So the femoral vein is here, the common femoral vein is here, and this is the great saphenous vein which connects over there. And this is how it looks like on the color Doppler. And this is a short axis view where you see blue going toward the head and red coming back. So venous Doppler, if your reflux is greater than 3 seconds and you have a stasis ulcer and you have stasis dermatitis, go ahead and treat the vein with ablation. If its reflux is greater than 3 seconds and the vein diameter is greater than 5.5 millimeters of the great saphenous vein and they have symptoms, you can go ahead and treat them. However, if they have deep vein reflux, then the only treatment for that is compression stockings because you really can't do anything. And if there's no reflux, you refer them for some other cause of the pain. So this is how it looks like a varicose vein. This is after treatment. This is the venous stasis ulcer that we treated and he healed up and no more. Thank you very much. So make sure you ask the right questions to your patient, and thank you for this quick brisk talk that I had to give.
Thank you very much. Khusrow, assalamu alaikum. This is Bashir. Thank you very much for doing this on such a short notice. I know you are in the cath lab working there and you still took some time out to do this. I'm really very, very grateful to you.
You're most welcome.
Just quick question I wanted to ask you is, for a cardiologist, what kind of training is required to really be able to do these things?
I think for cardiologists who are interventionalists, they really know how to maneuver catheters and wires in the vein, arteries. I think they need to understand the anatomy. Once they understand the anatomy, I think they should watch some procedures, and I would say at least they should watch 5 procedures of RF ablation or laser ablation and 5 of chemical ablation. And then I think if they start doing it, it would be a very good idea that they should do the first 5 under supervision of another physician. This is a number that I recommend even in states over here, but I think 5 is a pretty good number to start. But again, always ask help if needed, and not to let your ego come in and be afraid to ask for help.
Thank you. Thank you very much. If Anyone has any comments from the panelists on this? Otherwise, I'll let him go so that he can continue his cath lab work. Okay, so thank you so much.
Thank you.
Really appreciate it. Have a nice day.
Thank you. Bye-bye.
So we had this great session on complex coronary interventions. We started off with talks on bifurcation by Dr. Abidullah. Then we had the left main PCI talk by Dr. Suhail Aziz. And then calcified lesions by Dr. Umar Rana. And last was Dr. Nadir speaking about CTO interventions. So before I take questions from the audience, I would like to invite the chairpersons to have their comments about the sessions. So may I request Dr. Abdul Samad?
I think because of the time, maybe just a few quick comments. Anyone has it, and then we have to move on.
You have seen that interventional cardiology is now moving from the heart to the periphery, and when coronary angioplasty was introduced, then we were at that time struggling in NICVD with coronary bypass surgery, and the mortality was very high. And we used to have a cath conference in which we used to do angiograms, show it to the surgeon so that he can accept it for surgery. And the mortality was very high, and of course in those times the cardiologist could not afford to have no good relation with the surgeons, because he was the main person who was treating ischemic heart disease. So if a patient was a high-risk patient, we used to tell the surgeon, you operate on him on a Thursday, because it is said if somebody dies on a Thursday, उसके साथ कब्र का आज़ाद नहीं होता, तो हम कहते हैं उसको आप ऑपरेट करें थर्सडे को. He is high risk, he will die on Thursday at least. This world he will be gone, but he will be better when he is in his grave. So this was the situation when we started with the angiography, and that time stents were not available. And acute closure means urgent surgery. And in the West, the data was that 10% of these patients are going to need acute surgery at that time. This I am talking when angioplasty started, only simple balloon used to be there. And we used to do the proximal LAD, and as you know, proximal LAD is called widowmaker artery. So me and Dr. Haq, we used to sit and see, is this justified to do angioplasty in NICVD when surgery's mortality is so high? Because if we get an acute closure, then what are we going to do? If a planned surgery has a high mortality, then acute surgery surely will be highly fatal. So what we said that we can do two things. One, we will do pulmonary stenosis. Pulmonary stenosis, we will dilate pulmonary stenosis. We used to get a lot of pulmonary valvular stenosis at that time. They used to have open heart, and then they open the valve, and then these people used to develop pulmonary incompetence and go into right side failure. So we started, we should do pulmonary stenosis first, because there is no question of an acute surgery, and even if surgery is done, congenital heart surgery was established by Ghaffar Jatoi. He used to do all these patients with tetralogy of Fallot and ASD, VSDs. And the second thing we used to say, we used to do the peripheral artery, the femoral artery. Femoral artery, we And I tell you one clinical history, and then because of the time, I'm going to stop, but this is very educative. This was a lady who was 55 years old, severe diabetic, and she belonged to a community in Karachi. It's called Punjabi Sodagaran Delhi. Very rich community and very advanced people for health, education, and for tijarat, very advanced. This lady was diabetic and she had pain in the leg and she used to cry all the night, and I think her toe was also slightly ischemic. She used to cry all night. So her children came to me and he said, Samad Sahab, can you do something for her because she is in agonizing pain. So I and Dr. Haq Sahab, we said we should do an femoral angiogram and see what can we do about it. So the question was, should we do it from the same leg or should we do it from the other leg? What do you think? What should we have done? From the same leg, which is ischemic, or from the other leg? So I thought we should do it from the other leg, but Haq Sahab said, no, Samad Sahab, don't do it from the other leg. The other leg is all right. Do it from the same leg. Do it from the same leg. I said, okay, so we went there and she had a good femoral pulse, and you will be astonished that we found that the mid-femoral artery had a very tight stenosis. Not like the cases you were showing, very tight stenosis. Now the question is, can we have a balloon? Can we have a balloon with which we can dilate the femoral artery? So there was a vascular surgeon in civil hospital, I forget his name, but he came from Jeddah, and he was related to this very famous advocate, Pirzada Sahab. If you know Pirzada Sahab, when he used to come out, the Prime Minister used to tremble because he used to advise the President that this man cannot stay in office. He was a very great advocate. I think all of you have known him, and he is dead now. So he was related to him, and he had peripheral balloons. So Dr. Haq called him because he came one day and he says, if you do peripheral angiogram, I will do peripheral angioplasty for you. Haq Sahab said, no, you bring the balloon and we will do it. So he brought a balloon and we dilated that femoral artery. And next day we discharged her, and that lady was totally asymptomatic. The sons came and they brought us Nihari and Halim and all these things, to the NICVD, and we distributed it through everybody because they were so thankful that this is the first time in this week this lady has slept. So peripheral vascular disease is a very, very painful condition, and you can really help them. And those people who are doing coronary work, they can do peripheral work very good.
Thank you, Professor Samad, for those for sharing that wonderful experience. I have just 1 minute for a quick comment from the panelist, but we are already short of time, so I'll call this session off. Thank you very much.
Just take this opportunity to thank all the speakers. They have made the complex intervention look very simple, but for the juniors, it's a time to go back, learn under supervision, and then practice it. Things look very simple when an expert is delivering a talk, and they demand some more when you're really doing it in the real life. So good luck to every young, enthusiastic interventionalist. Don't